Hey there, I'm Luis Marcelo. We are going to talk about BaSICS trial, balanced solution versus saline intensive care study. And the study's question is among intensive care patients requiring intravenous fluid challenge, does the use of a balanced crystalloid compare with saline solution 0.9% sodium chloride improve 90-day survival? This was an investigator initiated randomized clinical trial conducted at 75 ICUs in Brazil from 2017 to 2020. The trial protocol and statistical analysis plan have been published previously. The trial was overseen by an external data and safety monitoring board and approved by each institution ethics committee, and all the patients or their legally authorized representative provided signed and informed consent. This study was a factorial trial that assessed both the effects of fluid type, balanced solution versus saline solution, and reported in this article, and compared two different infusion speeds to be used during fluid challenge: 333 versus 999. Patients were randomized if they were admitted to the ICU and needed at least one fluid expansion at the discretion of their attending physician, were not expected to be discharged the next day after enrollment, and met at least one of the following risk criteria for acute kidney injury. First, older than 25 years old. Two, hypertension, mean arterial pressure under 65 millimeters of mercury, or vasopressor used at any dose. Three, sepsis, defined as suspected or confirmed infection plus acute organ dysfunction. Four, required mechanical ventilation or non-invasive mechanical ventilation, including high-flow nasal cannula for at least 12 hours. Five, early signs of kidney dysfunction or oliguria for more than 3 hours, or serum creatinine level above 1.2 for women, or above 1.4 for men, or had liver cirrhosis or acute liver failure. The exclusion criteria were acute kidney injury requiring or expected to require kidney replacement therapy within the 6 hours after admission, severe electrolyte disturbance, especially serum sodium level under 120 or above 160, those whose death was considered imminent within the next 24 hours, those with suspected or confirmed brain death, and those receiving palliative or comfort care only. Patients were randomized via central web-based automated randomization system that was available 24 hours per day in São Paulo, Brazil. The randomized study group was disclosed only after each patient was registered in the web-based randomization system. And the randomization list was generated with online software using random permuted block size of 12, stratified by center according to the fluid type and infusion speed, two different speeds, and the block size was not disclosed to research personnel. About the intervention, the fluids were supplied to enrolling sites in identical 500 milliliters bags labeled only by a code corresponding to the fluid type A12. All fluid challenge, maintenance fluids, and drug infusions greater than 100 milliliters were requested to be performed using the trial fluid during the ICU stay up to 90 days after enrollment. Physicians, patients, and individuals who assessed the outcomes were blinded to the assigned treatment. And overall patient management, including the decision to perform fluid challenge, was left to discretion of the attending physician. Protocol adherence was checked at specific time points after enrollment, days 1, 2, 3, and 7. Their findings, this RCT included 10,520 patients in intensive care units and intravenous fluid bolus treatment with a balanced solution versus saline solution resulted in a 90-day mortality of 26.4% versus 27.2% respectively, a difference that was not statistically significant. I would additionally comment that they used a factorial design to increase efficacy, as there isn't any non-biological interaction between type of solution and its diffusion rate. They blinded physicians, patients, and individuals to assess the outcomes only for fluid type, not for infusion rate. But this research question is about fluid type specifically. About allocation concealment, they use a permuted block sizes not disclosed to each research personnel and identical fluid bags identified by code A to F. Apparently, it was very useful because at the end of the enrollment, they asked the principal investigator to guess the fluid type of each letter, and only 6 out of 66 guessed correctly the fluid type. So they studied strengths it was a multi-center, although all CUs were Brazilian, extremely large, more than 5,000 patients in each group. Regarding internal validity, they had a good randomization strategy, balanced baseline characteristics, and intervention was consistent over 90 days. The follow-up loss was very low, 0.2%. The post-randomization exclusion due to consent withdrawal was very low, 4.3%, with a homogeneous distribution among groups. And as limitation, I would add the protocol adherence verification in days 1, 2, 3, and 7 was around 60 to 80%, a medium high, however, at risk of contamination. 68% of the patients received fluids before enrollment at the emergency department and operation room. The high number of planned surgical admissions may have reduced the baseline mortality, influencing the study's power because they estimated 35% 9-day mortality. During the sample size calculation, it was around 26-27%. The only balanced crystalloid tested was plasma light, so it's unclear if the further types like ring lactate effects would be similar, and the amount of fluid received during the trial was smaller than the expected, 2 liters at day 1 and more 2 liters over the next 2 days, and day 7 less than 500 milliliters. Considering the dose response principle, it may have contributed to neutral result. They did not use intention to treat analysis, although the majority of those who did not receive the assigned treatment was due to the withdrawal of consent, and serum chloride levels hypothesized to be the cause of higher mortality were higher in the sodium chloride group, 108 versus 105. However, this difference probably had no clinical relevance.